And it starts with, I have no financial relationships to disclose. So to sort of frame the questions that we're thinking about, consider an 82-year-old woman who has been in long-term care for a variety of reasons, debilitated for several years, and you're called because the nurses note her to be increasingly confused, and her respiratory rate is elevated. She's working a little bit harder. There seems to be an area of crepitations, but she's not making any sputum, and her O2 sats aren't too bad yet. So the questions are, do we send her to hospital? Do you need to do an X-ray? If this is pneumonia, what's the most likely pathogen? If it's pneumonia, would you start antibiotics, and which one? How long would you treat for? And you could also put at the end, what should be done to minimize the chances of this happening? You know, what preventative strategies are there for pneumonia in long-term care? So the objectives of this talk will be to review, in the setting of long-term care for pneumonia, the epidemiology and microbiology, talk a bit about the presentation and how to make the clinical diagnosis, and then specific treatment guidelines and some preventative strategies. So epidemiology of pneumonia, it's common. In 2004, the US did a survey of long-term care facilities, and at that point in time of the survey, so the sort of prevalence at that moment in time, 2.2% of patients in long-term care in the US that they surveyed had an active diagnosis of pneumonia. So that's huge. Second in infections, second only to urinary tract infections at 5%. So urinary tract infections, even more common. Each year, between 8 and 20% of patients in long-term care get a diagnosis of pneumonia, and it carries a massive mortality. In the States, as I'm sure you're aware, the Veterans Affairs looks after a huge burden of elderly patients, and they find that the 14-day mortality is 23%. So this is not a hospital mortality rate, this is long-term care, and these are unhealthy patients. If you look at people who have pneumonia, 75% of them die within 1 year, compared against an already staggering mortality, however, of 40% who don't get pneumonia. So this seems to hit the weaker patients, and it has a very high mortality. I like to say all pneumonia is from aspiration. So you inhale viruses and some atypical pathogens directly deeply into the lung, and that leads to infection. But essentially all bacterial pneumonia comes from aspiration. Streptococcus pneumoniae, Haemophilus influenzae, they colonize the oropharynx, and then they're micro-aspirated into the lungs. That's really the pathogenesis of how this happens. So the risk factors for developing pneumonia really revolve around the risk of microaspiration, and the inability to handle secretions is the main thing. So general debilitation and weakness, swallowing difficulties, obviously, NG feeds. So even if they're not actually taking nutrition orally, if they're NG feeds, they still are at a significant risk. Confusion and sedation and agitation, chronic lung disease, and one that I'll talk about even more later is dental disease. So having significant dentition problems predisposes to pneumonia significantly. What causes pneumonia? So I'm not saying Donald Rumsfeld was a good Secretary of Defense or even a good man, but I like his idea of known knowns and known unknowns and unknown unknowns. And really in long-term care, pneumonia is an unknown unknown. It isn't particularly well studied as to what's causing it. It's hard to look at pneumonia causes in general because we usually don't get an organism even in healthy patients. And in long-term care, it's even harder. I'll say though, viruses are common, very common, and often severe. So we think about influenza being a particularly severe and common respiratory virus, and it is, but other viruses are also very common. There was a study that was done in Boston, I believe, and it was initially for vitamin E in long-term care patients. I don't know why people used to look at that. They took serology, they took blood at one point, and they took it a year later. And it wasn't a very good study, but they looked at virus responses. So did people have a serologic response to a respiratory virus, 8 specific ones? And they found that 41% of patients had at least one viral infection, indicating that their antibody titers to one of these respiratory viruses went up. So the most common was actually metapneumovirus, not influenza, but influenza, RSV were all very common. So huge burden of disease, very, very high prevalence of viral infections in long-term care, and not always just influenza. Lots of other respiratory viruses can move through that population. Difficult to diagnose. We have molecular techniques for doing the diagnosis of viral respiratory tract infections, but it's expensive and the lab is not really willing to do it on everyone only in specific patients at risk, so immune compromised, etc. So you need clinical clues. So rhinitis and a runny nose is not in keeping with a bacterial infection. Conjunctivitis and a wheeze also features that suggest viral. A lack of sputum production is not always going to be helpful because in long-term care the patients are weak and they're less likely to actually be producing purulent sputum. But a completely dry cough again suggests a viral process sometimes. Some viruses can cause a really good lobar consolidation. So it may look and sound just like bacterial pneumonia, but can still be a virus. So always consider whether it's more of a viral process, but it's difficult and we don't have readily available microbiologic assays to look for this. We talk about atypical bacteria, and these are the three main ones are Chlamydophila, Legionella, and Mycoplasma. So Chlamydophila can occur in long-term care, but it's generally a low severity infection. Legionella, outbreaks can occur. So Legionella, I'm sure many of you have heard, got its name from a Legionnaires convention in Philadelphia. The HVAC system at that hotel, the water was contaminated with Legionella, and it dispersed it and caused a huge outbreak of Legionella disease. And that can still happen in institutions, and it still does happen. And the illness is typically very severe with a high mortality rate in people with significant comorbidities. Thankfully, there's little Legionella in BC. Not no Legionella, but little Legionella, unlike other parts of North America. So it's possible, but unlikely that we're going to see significant amounts of this in our long-term care facilities. Mycoplasma pneumonia isn't really a significant concern in long-term care either. So I'll mention one other bug that's sort of an atypical bacteria. This is from a March of Dimes campaign. Tuberculosis, the foe of youth. It's more the foe of the immune compromised and elderly now. So patients in long-term care are at a higher risk, both because their increasing age and their comorbidities lead to an increased chance of reactivation. And as well, these people were around for the most part when TB was a heck of a lot more common, even if they're born in Canada. So they were around in the pre-treatment era and much more likely to have been exposed as a child and have picked up latent TB. So they need to be screened. I could not really find the screening guidelines in the BC CDC. I'm sure they're somewhere, but patients are generally screened. But it's important to realize that screening can still miss cases. So always in the back of your mind with a respiratory infection, the question of could it be TB? And lastly, what we're mostly worrying about for high mortality and the ability to treat it are bacterial pneumonias. So we know in the community, elderly patients, the predominant pathogen is Streptococcus pneumonia. That goes across actually all ranges of pneumonia in the community. And in long-term care, it's really poorly studied. This is where the unknown comes in. It's hard to get sputum from weak patients. If you really wanted to get a good study to look at long-term care pneumonia, you'd have to do bronchoscopies on them to get samples. That isn't going to happen. Diagnostics are less available, so it's harder to sometimes make a solid diagnosis of bacterial pneumonia, and as well, the ability to get good sputum samples, even if they are producing sputum, is reduced. And there's little focus on this population as well, as opposed to acute care or the community. There's been attempts to do it. There was one Spanish paper, and it looked at 150 patients who were sent from long-term care to hospital for a diagnosis of pneumonia. And they found a cause in only just over a third of cases. So in up to 2/3, they didn't find a cause. Could have been bacterial, possibly they had one of the many viral pneumonia conditions. When they found a cause, Streptococcus pneumonia was by far the largest amount of it. But still, only 22% of all cases that this is what was found. Significant numbers of gram-negatives and Staph aureus infections were also found, though, so a little bit different than the general population. A comment on aspiration pathogens, and I'll talk a bit more about specifically aspiration pneumonia later. But we think about aspiration being after macroaspiration or recurrent microaspiration, and what we mean by that is generally normal oral flora. So Viridans group Streptococci and oral anaerobes. But you can also get gram-negatives. So we know in the hospital, when people are unwell, there's a shift in oral flora, and you start to see enteric flora, E. coli, Klebsiella, etc., getting into the oropharynx. And these can be microaspirated into the lungs. And as well, if a patient actually aspirates their gastric and duodenal contents into their lungs, there's enteric flora in there. So when we're talking about aspiration, it's a somewhat different set of bugs, and these are the ones, normal oral flora and enteric flora. So to summarize the sort of microbiologic causes, viral pneumonia is really, really common. There's a lot of viruses in long-term care. They're hard to diagnose, and we don't have good lab ways of doing that. Bacterial causes, it's a bit unclear to look at exactly what's causing it, but it seems that Streptococcus pneumonia is still the most common, as it is in the community, but that gram-negatives and Staphylococcus aureus tend to be a bit more common than they are in the community. And atypicals are not really a significant problem in long-term care, at least in BC, because again, we don't have that large burden of Legionella disease. Remember, think about TB. And aspiration pneumonia is going to involve normal flora, oral strep, anaerobes, and coliforms. Aspiration pneumonia. So I left this up because when I first gave this talk, I used the Canucks as an example of choking, and I thought, it's sad how much has changed in a year and a half that we don't even think of them as choking anymore. They're not even taking solid food to choke on anymore. So we think about aspiration, and we talk about this a lot, and there's sort of three ways of looking at aspiration, three clinical conditions. So there's pneumonitis, and this is a chemical reaction to mainly gastric acid that's in the lungs. Comes on rapidly after aspiration. Patients can be very sick, have consolidation and changes on x-ray, can have fever, but it's not an infection, and antibiotics are not the answer. Aspiration with obstruction is when people have massive aspiration and they mechanically obstruct their airways. And then there's what we talk about more, which is aspiration pneumonia, and that's that recurrent microaspiration of normal flora. So it's not that they've picked up a bug that they've aspirated in, it's their own flora that they're microaspirating into their lungs over and over again, and it can include gastrointestinal flora as well. So the presentation is different in that it's often indolent. This comes on slowly. If they're producing sputum, it's often foul because of the anaerobic content, sometimes brown. The common story is not that there's a witness macroaspiration event, it's that they're continuously microaspirating their oral contents. And if you don't catch it early, it often will lead to lung abscesses, as you can see in the right lung air fluid level near the hilum.
How do they do this microaspiration? Because they're cognitively impaired?
Yeah, so it's the cognitive impairment, it's the weakness. I mean, swallowing is a very complex process, and it's often the first to go as people deteriorate cognitively, strength, confusion. So for a large variety of reasons, that process is impaired. And we see it a lot, people presenting alcoholics or confused patients with recurrent microaspirations and lung abscesses.
So is it always right-sided?
No. So people talk about macroaspiration tending to have a predominance for the right side, but this more microaspiration process, I don't think there's any significant side predilection. So the presentation of pneumonia in long-term care is going to be different than the community. So if you look at long-term care patients to elderly patients in the community, they're much less likely to have fever, produce purulent sputum, and have pleuritic chest pain. So the classic story of they have fever, they're coughing up pus, and they have sharp chest pain, you're not going to hear that. They're much more likely to have confusion, become dehydrated, and have a decrease in their function from baseline. So much softer signs. This makes it a difficult diagnosis to figure out whether they have bacterial pneumonia. And it's difficult given the resources. This isn't the ward where they can come up and do a portable chest x-ray and draw blood. So you're looking at clinical signs. Tachypnea is often quite helpful. Increased work of breathing, if they have a fever, if they're hypoxic, and again, if they have that dehydration and confusion coming on. On examination, you're going to be looking for areas of consolidation or crepitation. And if you can get investigations, leukocytosis is a hint that you're looking at a bacterial process, a chest x-ray to confirm that there's an area of consolidation. If they're producing sputum, a culture to give you an organism. But note that blood cultures are of low utility in most pneumonia cases. The positivity in most people is low. We do it when people present to the hospital acutely, but I'm not sure it's a big help in most cases, with the exception of when it's a Streptococcus pneumoniae.
Are they able to give a good sputum sample?
No, and that's the problem is, it's difficult in well patients, even young patients, to get them to give a good sputum sample without oral contamination. As people become older, weaker, more confused, it's extremely difficult to get a good sputum sample. So If they're able to give that to you, if they're cognitively with it enough, then you can try. But a lot of the time, you're not going to be able to get any of these investigations, and it's going to be a clinical diagnosis. So the treatment, the first question is when to transfer. And of course, this is subjective, and it has to do with the patient and their wishes. If their care directive is to allow transfer to hospital, then reasons to consider transferring would be if they're significantly hypoxic, if they're going to be unable to take oral medications, if they're tachypnic and they're fatiguing, and if they're severely dehydrated. These would all be reasons that trying to treat them in long-term care setting for their pneumonia is likely not appropriate. So when I talk about treatment, I'm not going to talk about IV treatments significantly. When we're choosing the oral antibiotics, you need to consider what the likely pathogens are, the patient's comorbidities and other medications, and their allergies. And it's important to note that when we talk about treatment guidelines for pneumonia in long-term care, they're really not evidence-based. So I'll talk about the IDSA guidelines. There's always protesters outside the IDSA conferences, the Infectious Disease Society of America. It's probably the only major medical meeting that reliably has protesters. And they're protesting our stance on Lyme disease. So if you read this, his t-shirt says 2011 protest of the IDSA Lyme disease guidelines. So, and they're there every year. So IDSA has pneumonia guidelines, and they roll this all into one, and they talk about hospital-acquired pneumonia, ventilator-acquired pneumonia, and this entity that long-term care falls into, which is healthcare-associated pneumonia. People that have been recently hospitalized, people that reside in long-term care, who are on dialysis, or have recently had IV antibiotics or chemotherapy, and they lump it all together, and they suggest broad-spectrum nuclear antibiotics for all of them, without specific recommendations for long-term care, and starting with oral antibiotics isn't an option for any of them. So if your patient in long-term care is unwell with pneumonia and they need to be transferred to hospital, I suppose these guidelines may be relevant, but if you're dealing with them in long-term care, this is not really what we're looking for. VIHA has their own set of guidelines that they put forward for community-acquired pneumonia that specifically makes recommendations for long-term care cases. So in the community, the first line is amoxicillin, and that comes back to how Streptococcus pneumonia is far and away the main pathogen that we're dealing with. But the first line treatment in long-term care is amoxicillin clavulanate. So when you add that clavulanate to amoxicillin, you end up with essentially oral piptazo. There aren't too many things that this doesn't kill. And they recommend that if there is a penicillin allergy, that you use cefuroxime or moxifloxacin. So the ideas behind this recommendation of amoxicillin clavulanate being the main therapy is that atypical therapy is not really needed in long-term care. And the idea of adding a second drug, it may help in Streptococcus pneumonia cases. And in people who are significantly ill with Streptococcus pneumonia, it does help and is done in hospital. But it's not clear that it helps in long-term care and isn't necessarily recommended. And the use of the broader amoxicillin clavulanate is because this is going to cover staph as well, anaerobes, and especially enterics, so most E. coli and Klebsiella, etc. So it has good coverage for all the different possibilities that you may be seeing in long-term care, as opposed to the community where you're really focusing on Streptococcus pneumonia. So what about if your patient has had this to a penicillin before? So if the patient has a mild reaction, so if the story is that they had a drug rash that wasn't immediate onset, didn't involve angioedema or anaphylaxis, then you can still use cefuroxime, another beta-lactam, because of low risk of cross-reaction, and even if there is, it's not too serious. It doesn't have a lot of anaerobic coverage, so it's not adequate coverage for aspiration pneumonia in and of itself, if that's what you're treating. If they have a severe reaction to penicillin, then that's when we suggest the use of moxifloxacin, and it has fairly good anaerobic coverage. So the key is moxifloxacin is sort of fairly far down the list of things to use. They all have adverse effects. The big one with the moxclav is the GI and upset. It's significant, nausea, vomiting, and not so much vomiting, and diarrhea. The nausea and gastric upset is much better if the patient's able to take the medication with food, but it still is poorly tolerated by many people. Moxifloxacin can also cause diarrhea and is much more prone to inducing C. difficile than amoxiclav is. So amoxiclav is not that prone to inducing C. diff. Moxi definitely high on the list. It can prolong the QT, So if they're on other drugs that prolong the QT interval, this may not be appropriate. And there is a risk of tendinopathy, which is an increased risk in the elderly and people with chronic kidney disease. Moxifloxacin is one of the lower risk quinolones, but it still is there, so you need to be aware of it. Cefuroxime is generally well tolerated, can cause diarrhea or gastric upset. So if you notice, I didn't mention macrolides. So when you look at the antibiogram for Streptococcus pneumonia in VIHA, about a quarter or more of our strep pneumo is macrolide resistant. It doesn't cover the anaerobes in aspiration. It's not very good for E. coli, Klebsiella. It's not that really a great staph drug most of the time. And it can have significant drug interactions that are common and severe. And particularly clarithromycin. So you can see this was for the drug reps. They were advertising that they could go out and take over azithromycin's role with their long-term Biaxin, but tons of drug interactions with clarithromycin especially. So not really an appropriate drug in many patients with polypharmacy, and not a good drug as far as what it covers. So to summarize what antibiotics to pick, the first line for all pneumonia in long-term care is amoxicillin clavulanate. This covers pretty much everything that you need. If they have a mild penicillin allergy, you can use cefuroxime. But remember, it doesn't cover everything for aspiration. And if they have a severe penicillin allergy, moxifloxacin. So moxifloxacin is fairly far down the list. You don't generally need to cover atypicals, although always question whether it could be TB. And remember, moxifloxacin is not first line, and the macrolides are really not that useful in this setting. How long do you treat? It's surprising how little duration of treatment has been studied for most common infections. It hasn't been studied very well at all. And anytime they study, it seems like they come back and say, well, actually, you can treat a lot shorter than we used to think. So maximum of 7 days for outpatient Streptococcus pneumonia is adequate. 5 days has also been shown to work. Some people have looked at 3 days and it seems to work. You need to lengthen this course of therapy, though, if the pneumonia is complicated. So if it involves effusions, or if it's related to Staphylococcus aureus or other organisms. So it hasn't, again, been specifically studied in long-term care, but for the large majority of patients, 7 days should be adequate. Aspiration pneumonia, though, often forms lung abscesses, and these need to be treated for weeks and weeks and weeks. So if a patient has the indolent course, foul sputum, not a story that looks like Streptococcus pneumonia, then they may need a very long course of therapy. So the last area to talk about is how do we prevent pneumonia in long-term care? So conservative measures to reduce aspiration, of course. So having patients with swallowing difficulty be upright, thickened fluids if appropriate. Oral care is very important because poor dentition is highly associated with pneumonia, and it's a risk for aspiration even if the patient isn't taking anything orally and is getting tube fed. Wearing dentures overnight in community elderly has been shown to almost double the risk of developing pneumonia. So again, that's going to apply to long-term care patients as well. And it just shows that oral care is really highly linked to this. A difficult problem to fix in some of these patients, but things like dentures overnight, not helpful. And then the big thing to do to prevent is vaccination. So we have 2 pneumonia vaccines available to us. A 13-valent conjugate vaccine, where it's the capsule from the pneumococcus and then an immunogenic molecule to make it more reactive. We use it in little kiddies because little kids don't react well without the conjugate. And this one reduces the colonization of strep pneumo in the pharynx. And then we have a polysaccharide vaccine that has more kinds of capsule in it, but not the conjugate. So it's not effective in little kids, and it doesn't decrease colonization. US guidelines have said for a couple of years now to give the conjugate, and then a year later, give the polysaccharide in elderly patients. Canada does not yet suggest that, but a recent posting from the PHAC, their Canadian Vaccine Advisory people, is they're actually looking at updating that. So they're not yet saying that in Canada we should give conjugate and then polysaccharide, but as we usually do, we move a couple years behind the States, and I'm sure that by next year that will be our recommendation. So at that point, the schedule will be at 65 to give a dose of conjugate, and then a year later, a dose of polysaccharide vaccine, and then 5 years later, another dose of polysaccharide vaccine.
So what's the guideline now? We did 8 weeks later.
Yeah.
13 and 8 weeks later, pneumovax.
Yeah, so In immune-compromised individuals, they push together to 8 weeks. That's sort of the minimum that they want between the conjugate and the polysaccharide vaccine. In people who aren't immune-compromised or at really high risk, they do suggest up to a year. But realistically, 8 weeks is probably enough that you're going to have a good response to the polysaccharide vaccine.
So do I have to give Prevnar before pneumococcal? Is that?
That's the idea. It hasn't come out as a blanket advisory. It's what we're doing now for people that are at high risk of pneumococcal infection, so people with certain immune deficiencies. But it's not a blanket recommendation that all patients over 65 get the conjugate vaccine. The update that they came out with is saying that they're looking at it. So within the next year, I think that will become the recommendation, just like it is in the States. But as of yet, we're still, the recommendation is not that that's what everyone should get yet. Yes.
Most people, a lot of people now have polysaccharide.
Mm-hmm.
So is there some reason that the reasonable enough effect on the conjugate to even get that close?
And I haven't seen anyone clarify that yet. That if you've already had the dose of the 23-valent, should you now then 5 years later get conjugate? And then I haven't seen that answered. Eric, have you seen that?
No. I guess I'd say that you're right that ideally someone would get the conjugate and then wait at least 8 weeks, 8 to 12. But it could be any time in the next year. You could give the polysaccharide and get a significant boost effect. I haven't seen your question answered. Most people who get the conjugate actually have had the polysaccharide already. Mm-hmm. I think what we'll probably do is boost them again 8 to 12 weeks later with another polysaccharide. But then I don't believe there's going to be more boosting with polysaccharide down the road, like as we go down the road using conjugate in the elderly. Now, you're right about the Canadian guidelines don't come out and state this, but I think the BC guidelines do. Like, isn't the BC CDC or like, aren't there BC guidelines now? Because isn't it about 8 months ago we were able to prescribe Prevnar, and I have some patients getting it for free now. So I think in BC they can.
Yeah, I think it's covered, but I think that's what the Canadian guidelines are saying is this is a reasonable thing to do. Yeah. But it's not a blanket statement that everyone gets this yet. But it will be in the next year. But it's an interesting question. If you have a 70-year-old who's had the polysaccharide vaccination and they're due for the next polysaccharide, should you give them conjugate? And then I'm sure there will be recommendations as to exactly what to do with that algorithm, but not yet.
So I thought after 65, if you give pneumococcal, you give only once. You don't give another 5 years later.
Yeah. Again, I think the Americans boost at 5, and I think it's recommended to boost 5 years or more later.
5 to 7.
Yeah.
I thought it's one time.
I actually looked this up just the other day for a patient. So she was at a pharmacy, and the pharmacy said she could get the conjugate for $100.
Mm-hmm.
So, and I looked at the BC guys, and I don't think it is recommended for elderly. So it really talks
not yet. It's immune compromised in kids. Yeah. But I think within a year, it's going to be, that's the recommendation, is that they get the conjugate as well now. And again, the States has been doing it for years, and it seems to have a significant impact.
I guess my patients are compromised enough, because I've been sending them to the pharmacy for the conjugate, and they're getting it. But I guess, they have other things. They have HIV, they have other things. So they're meeting criteria that way.
Yeah.
How much does the polysaccharide vaccine actually work? Isn't there a fairly kind of therapeutic mileage? Does it really
This is a good question. So we talk about vaccine efficacy, which is you study population, and effectiveness, which is more of a population level afterwards. There was a Cochrane review that looked at efficacy, and the polysaccharide vaccine, both of them in the Cochrane review, seem to be very effective. Specifically in long-term care, in 2010, they did a randomized control trial of about 1,000 long-term care patients who were quite old with the polysaccharide vaccination. And they found that over 2 years, the polysaccharide vaccination reduced by 2/3 pneumococcal pneumonia, almost half all-cause pneumonia, and reduced by 1/3 death from pneumococcal pneumonia. So it does seem to be beneficial. So no one has yet done this comparing conjugate plus polysaccharide to polysaccharide, but it does seem that the polysaccharide has significant benefits. You're right, there is some nihilism in the polysaccharide vaccine in that it doesn't reduce colonization. So it seems to reduce disease, but the bug is still out there. But it does seem to be an effective intervention. So to summarize, pneumonia is very common. About 2% in that US survey at that one point in time in long-term care had pneumonia. It's caused by both viruses, which are very common, and bacteria, with strep pneumo seeming to be the most common bug. Atypicals are rare in BC, with the caveat that Legionella exists and an outbreak isn't impossible. Consider TB. The diagnosis in long-term care is going to be mainly clinical. Tachypnea being key, you're going to have a hard time getting sputum samples. Your first-line antibiotic is amoxiclav. If they have a mild penicillin allergy, cefuroxime. If severe, that's when you start using moxifloxacin. So moxifloxacin is not the first line. 7 days is going to be long enough for most patients. And in strep pneumonia, that's probably actually a couple days longer than we need. But if you have Staph aureus pneumonia or lung abscesses, they're going to need longer therapy. Pneumococcal vaccination seems to be an effective intervention in long-term care facilities. And there's lots of conservative measures to reduce aspiration, especially those looking at dental health. And that's it. So if there's any other questions? Yes.
Do you think it's worth putting people on Tamiflu too? Or?
So I'm a Tamiflu nihilist. It has a public health benefit, and I think that's where a lot of it is used in the long-term care setting, and as sort of decreasing transmission. And I'm not a nihilist there. I think that's great, but I don't think giving Tamiflu to somebody with influenza has ever really been shown to impact outcomes. I know some people disagree with me, but Tamiflu is a funny drug in that people have viewed it, as the answer to influenza, and really, when you drill down into the studies that have looked at its effectiveness, it hasn't done a heck of a lot. So it decreases shedding, which is important for infection control, but beyond that, I don't think. I mean, we do it, right? If someone comes into the hospital now with a pneumonia, they're going to get Tamiflu while waiting for the influenza, but Eric, have you ever seen anything that says Tamiflu significantly improves outcomes?
Yeah, it's not very good data. I think the biggest place you'll use Tamiflu is in more of a outbreak, contact, infection control, public health sort of setting where you've got already a documented problem in a long-term care facility. That's where Tamiflu saves lives.
And it's going to save lives not by treating people that have influenza, but by decreasing the number of people that get influenza in that institution. So, yeah.
We were just updating our contingency formulary at the nursing home I work at, and we were going to add amoxiclav because of the call at 10 o'clock at night, and you want to give something that's not going to damage kidneys and be available. So we were looking at either having the 875 twice a day or the 500 3 times a day, because the pharmacist doesn't want to have both on the formulary.
Yeah.
Which one would you recommend?
So I usually use the 875 because it's twice a day, so the stomach upset is less. I would stock the 500 though, because in impaired renal function, you often don't want to use the 875, and the 500 twice a day is actually going to be your renally adjusted dose.
So 500 twice a day.
So you have to renally adjust the dose. So the 500, the dose is 3 times a day, but in renal impairment, you could drop that to 2 times a day. So the 500 is going to be more useful, I think, to have on the formulary.
The reason we were having this discussion was that I guess the clavulanic acid portion is higher in the 3 times a day dose, right?
Yeah, the total,
So
total amount is a bit higher.
So that was our discussion, was do we want to, which one do we give?
So again, and that's why I like the 875 as the main one, but I imagine that a lot of the patients that need this are going to have impaired renal function, and the 875 dose is not what you use when someone has a GFR of 30. So for that reason, it may be more convenient if you can only have one to have the 500.
Okay, thank you.
So right now that we do for kids, the difference between kids and adults. So you don't mind asking this question?
I think it's the exact same, just a different dose. I don't think there's a difference.
What's the dose difference? That's how
Oh, sorry, that I don't know.
Because there are people who cannot afford the Pneumococcal.
Yeah.
So I was wondering
It's true, and that's why, I think it's probably a good thing to have, but I wouldn't push everyone to go out now and have patients with financial problems go buy their own conjugate vaccine. But I bet you within a year it'll be covered as part of the vaccine schedule. So that's what I took the PHAC thing from last month to mean, is that they're actively considering it and will quickly be coming out with a new recommendation to follow the Americans, just like we do every time. Right, yeah.
Sorry, I just, because you said that a lot of these infections aren't really all that well studied.
Yeah.
How are you so sure that there aren't more atypical infections? Because I'm kind of thinking that some of the infections come from workers who maybe pick the bugs up from their kids.
So they definitely could be. So Chlamydophila and Mycoplasma are generally fairly mild illnesses. Not always, but they're not that significant of an illness. Legionella is the big one that we would worry about, and we just don't have a lot of it in BC. We see sporadic cases, but we're not a highly endemic area for Legionella. So,
and someone who's really run down, wouldn't a Mycoplasma pneumonia be fairly difficult to deal with anyway?
It could be. The problem is if you want to start covering all those things, then you have to start chucking more drugs in, and you get into more side effects, drug interactions, and it's tough. You're right. It's tough to diagnose things like Chlamydophila and Mycoplasma without something to suggest that it's a big problem and that there's a benefit to doing it. I'm not sure there's a huge reason to start adding macrolides and quinolones and tetracyclines in, though. You're right. It's a good point that if we have 2/3 unknown, what is it? But
Lots would work in that situation.
it would. So, and I love moxifloxacin for certain things, but the problem with using moxifloxacin is drug interactions, QT problems. It is definitely a very C. diffigenic drug. We see a lot of C. diff triggered by that. And as well, when you start pouring moxie into the community, especially a community that's likely already getting a lot of Cipro for urinary tract infections, resistance is a significant problem. So moxie is good, and we use it for pneumonia, but it's not first line. And even in the hospital, we don't really hit the people with pneumonia hard with atypical coverage. When they have pneumonia and they're really sick, it's usually going to be Streptococcus pneumonia. That's the primary bug. And Mycoplasma and Chlamydophila make people unwell, but they generally don't make people super unwell to the point where they present to hospital. And it's a good thought. The best study would be to take those 150 patients that are transferred and give them all bronchoscopy to get a culture and do a PCR and to really answer that question. But I don't think we have the answer. And I, at this point, don't think adding those other drugs is of a benefit. So.
You're suspecting TB, what are you supposed to do then?
Yeah, so TB is going to be indolent. They're going to have a slow onset. They're going to have fevers, sweats, weight loss. And TB is going to be rare in long-term care. I only mention it because it's really important to catch, because there's nothing worse in the ward than that realization a week later, oh crap, this could be TB. We've had 50 healthcare workers in the room, and they've been in the sunroom, and so it's just important to think about it, because if it is, you need to get a sputum sample for AFB and isolate the patient if you're really suspicious and catch it early. The problem with TB is always when people are caught really late and there's been a huge exposure to other people and patients.
Just a comment and then a question. We're really trying to dissuade people from using Moxie so much, and it's there was a time a decade ago when the fluoroquinolones like Moxie, the respiratory quinolones, became at the top of the list. And if you looked at the Canadian guidelines for treating community-acquired pneumonia, and we've come a long way from that. It's being pushed further and further down. We're seeing more and more side effects, black box warnings, neuropathy, musculoskeletal problems, QT, drug interactions, and let alone rashes and other things. These drugs are just more complicated than we used to think. Really the message is give a beta-lactam if you can. And But you, in your entire talk, you didn't mention my one favorite drug. And I'd like to ask you about doxycycline's coverage of strep, because the occasional patient may actually have a significant beta-lactam allergy and some other reason why you can't give moxie.
Yeah.
And I agree that I would not bother giving a macrolide. 30 to 40% strep pneumo resistance to macrolides, don't order
Yeah.
it. And I agree that I don't think we need to be covering atypicals the vast majority of the time. So doxy might have a role. I guess it would be maybe next on the list, if you
Yeah, so I'd have to look at the
trouble there.
antibiogram again, but I think strep pneumo in VIHA, it's not bad. It's better than the macrolides, but it's still about 20% resistant. So pen resistance in our strep pneumo, essentially zero. You know, I've seen one case in 4 years.
High level, yeah.
Yeah, of high level of pen resistance. So beta-lactams are always going to work, basically. Macrolides, really bad. Doxycycline's somewhere in the mix. So it's a good point, and I probably should put in there, doxy wouldn't be my first line, it wouldn't be my second line, but if you can't use a beta-lactam and you can't use moxie, I mean, you can always call us when you get really hung up on allergies like that and problems, but doxy is probably a pretty good one. Clin is so-so one. Yeah.
If you're in trouble.
Yeah.
Great, thank you very much.